Hey everybody, I am Danae Peterson. I'm your host today for Eye on Research, and I just wanted to give you guys a heads up of what's going on today. So thank you for being with us. Thank you for registering, and we are so excited to have our speakers. Dr. Carvajal has put together a huge lineup of wonderful speakers, and we are all thrilled to be here, and we can't thank you enough. I just want to give a huge thanks to our sponsors for making this possible. These are some of the sponsors from our last I Believe meeting, and they are so generous in helping us to be able to put on these kinds of meetings. So thank you to Castle Biosciences, IDEA Biosciences, Aura Biosciences, Immunocore, and Delcath Systems. If you're here and you have to go for any reason, please don't stress. We're going to be live, but we are also recording these sessions, and you'll be able to catch them on our YouTube channel after they're edited, or on the I Believe podcast for just audio only. I would suggest, however, that you go and subscribe to our YouTube channel because the YouTube channel is going to be where you're going to see all the slides. All right, so I'm going to go ahead and bring Dr. Carvajal in, but here's kind of what our agenda looks like. We've got a 10 a.m. session. It's going to last about an hour to an hour and a half. And then we've got an 11:30 or whenever we finish the last session that we're going to run into. First session is going to cover metastatic treatments and trial updates for the systemic and the liver-directed areas. After that, we're going to do a Q&A until we get to when we need to start session two. And then we're going to do some adjuvant therapies, and then we'll have a Q&A and finish. So with that, I'm going to go ahead and bring Dr. Carvajal on.
Yeah, thank you, Danae. And I'd like to thank Ocular Insight for hosting this event. Want to thank the sponsors. This is really important. I'd love to thank our lineup of speakers. And of course, I'd love to thank all of you for being here. So as Danae said, we have a pretty nice agenda for this morning. And what we wanted to do was make sure we had time for Q&A. There's a lot to talk about. And I just wanted to kind of start off by setting the stage. As I hope everyone on the webinar knows, there has been incredible progress in how we're able to treat people dealing with this disease. It's not enough. I always say there's much, much more that we need to do. But if you think of where we were just 10 years ago, for instance, compared to now, it's a completely different landscape. And I think that is a testament to the hard work of a number of groups, not just the researchers understanding the science and trying to develop new therapies. This is also our industry collaborators. We cannot do that and some of whom are sponsors for this event. And I can say there's always obviously a business aspect to all of this, but everyone we have worked with in industry, their heart and soul is here for the patients. And then lastly, I think the partnership with our patients, family members, and advocates has been fantastic. And seeing organizations like Ocular Insight come together and grow over the years, it's been really fantastic. There are going to be a few different sessions. We've got a number of speakers, some of you whom are going to be able to stay for the whole time and some of whom are not. But Justin Moser, as many of you know, outstanding physician, beloved, and really making incredible progress in kind of the research field. He's at Honor Health. Dr. Cam Montazari, fantastic physician in Boston at MGH, also doing a ton of research leading the uveal program there. Sessions 1 and 2 are really the advanced disease session. We're going to spend a little bit of time talking about some of the key developments in terms of developing treatments for metastatic disease. And then the second part is going to be what we call regional therapies, and we'll talk about that a bit. After that, we'll talk about something I'm really excited about, which is the development of, I think, really promising therapies in the preventative setting. If we can prevent the development of metastasis, that's how we're going to increase the number of people we can cure. The drugs and the therapies we're talking here, this is just a subset of what's out there. But I think we're hitting on some of the high points that we want you to know. We're going to be focusing not on what's been done so much, but what the future is. Okay. And so for session 1, we'll spend a little bit of time talking about tebentafusp. Dr. Moser will spend a little bit of time talking about the Iontura program, and Dr. Montazari will spend a little bit of time talking about the IDEA program. So I wanted to spend a few minutes talking about tebentafusp, a little bit of where we've been, but again, where we're going with this. I want our patients, family members, caregivers to know what we're doing, why we're doing it, a little bit of how these things work, and why we're so excited about these therapies. So tebentafusp is a type of drug that we call this bispecific molecule. And by bispecific, it just means it's got kind of two ends and two functions. This is a little bit a little cartoon of what this is, and I'll just walk you through this. But tebentafusp, on one of the ends, there's what we call an optimized T cell receptor. And what that lets us do is have the drug bind really tightly to a protein on the surface of the cancer cell, right? So if this up top here is that uveal melanoma cell, there are proteins that are expressed in something that we call this HLA context. So this HLA molecule presents this protein, and tebentafusp is this dark blue thing here that binds to that really, really tightly. And the protein that it binds to is this thing called GP100, which is, expressed really highly on those cancer cells, right? So it binds to the cancer cells wherever they are. And then the other end, the other part of that bispecific piece is something that functions to really suck in immune cells that are in that area, okay? So basically drug binds to cancer and then brings the immune cells to that cancer. And that by itself is enough to allow the immune system to kill the cancer cell. It's pretty cool, right? So the development path for this, there were kind of two trials. I'm not going to spend too much time talking about those, but as you can see in the eligibility for both of these, for this thing to work, patients have to have this certain HLA type. And so we say they have to be HLA A0201 positive. Basically, we determine that based off of a blood test. You can also kind of do it from tumor, but that's a little bit complicated. It's better to do this from a blood test. And it really tells us how your immune system functions. About 40% of people with uveal melanoma will have this HLA type, and that's the population for whom this drug can work. The other thing I want to highlight on kind of that blue thing is that where it says like tebentafusp 20, 30, 68, the way we give this drug is it goes by vein. It's an IV treatment. We do it once a week. But in the beginning, we have to start at a low dose for the first week, then go to a slightly higher dose for the second week, and then that 68 micrograms, which is the highest dose that we get to subsequently. And the reason for that is a fewfold. One, we know that this drug works better if the doses are higher. But when this drug was being developed, if we gave really high doses at the beginning, people got very sick. And so using this strategy helped us get to the higher doses and helped minimize the side effects that people got. When we think about the side effects, there are a few things that we talk about. One, I'd say there are two categories of side effects we usually see. One are skin side effects, and that happens because the melanocytes, the pigment cells on the skin, also have that GP100 protein, right? So that drug binds to your skin cells, bring immune cells to your skin, and that causes rash, itching, kind of a sunburn type reaction. And the other type of side effects that we see are what we call cytokine mediated side effects. And these are side effects from your immune system becoming very hyperactivated. And what do we see? We see things like fevers and chills and even drops in the blood pressure. It turns out those side effects are most severe in the beginning, and then over time they kind of go away, right? And so that's why we start with that lower dose, which still gives the high frequency of side effects. During the first 3 doses, current state, almost all centers will monitor people in the hospital or hospital setting for at least 23 hours, just to make sure they're okay. And by the 4th dose, it's all able to be given as an outpatient. And what you kind of see here is, if you look at that week 1 section, and if you look at the bar, about 20% of people have like this dark blue bar, which are kind of the bad side effects, with most of the side effects being rash. But over time, you can see that dark blue bar really decreases. And I will say that my experience is that by the 2nd or 3rd month, patients have virtually no side effects. And in fact, they forget that they had any side effects in the beginning, which is kind of interesting. Something important for you guys to know, we're really working to figure out how can we minimize the side effects. And I think a lot of us who treat people with disease have found different things to do this. Using Tylenol and Benadryl before dosing has been helpful. People used to have issues with drops in the blood pressure, which led to problems, but I think most of us are starting people on IV fluids during the course of treatment and for the course of 12 to 24 hours. And that seems to prevent that. And now we're starting to look at, if we give a little bit of steroids before the first few doses, can that minimize the risk of side effects? I think as we get better at that, it may be possible to just start doing all of this as an outpatient with very, 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 very close monitoring overnight at home or at a hotel near the hospital, just in case problems happen. There are a lot of key outstanding questions despite all the work that's been done. I just list some of these here. I'm not going to go through all of these. It just highlights kind of what are we doing in the field in terms of making TEBI easier and better to I don't know, easier to treat and work better. One question is when should HLA testing be performed, which is that test to determine can this drug work or not. And I think I'd love to hear what Dr. Moser and Dr. Montazari kind of say. Definitely, I would say, 6 months ago, a year ago, the definite answer was at the time of if the cancer comes back, you have to do it. Some people would say maybe we do it at the time of diagnosis of the primary melanoma if we're worried that there's a high risk that it might come back. I would say now, because of some of the new preventative therapies, the adjuvant therapies that are effective, I think if you're considering preventative type therapy, I would definitely recommend testing at the time of diagnosis of high risk primary disease. We're looking to see if side effects can be minimized. You look at the steroids. Do we really need that 23-hour hospital observation? Is there a way that we can manage this easier? And if you look at point 9, do we have to dose this weekly, or are there easier schedules that we can do that's important? Point 4, when do we use tebentafusp? It was approved for kind of any line. The big trial was done in the frontline setting. So at the time of metastasis, the first time, but it definitely works later as well. Point 5 is, should we be using tebentafusp alone, or can we combine it with something else to make things better? Can we predict who this drug's going to work for, who it's not, right? That would be an important question. How long should we use this treatment? And I will spend a little bit of time on that. And then, if you get tebentafusp for a while and then you get another treatment, can tebentafusp later on work? That's another question. So to answer some of those questions, this is really important. I want you guys to know kind of what the kind of trial portfolio is and what some of the key things are. Not that you're going to go on any of these trials, but I think it's good for you to be aware. And these are I think they're all of the ongoing and upcoming TEBI trials that are slated. I may be missing some, but I've broken them up also by kind of different disease settings. Dr. Orloff is going to be on in a little bit, and she's just opening up what we call a neoadjuvant tebentafusp trial. That is, at the time of diagnosis of the primary uveal melanoma, before we do plaque brachytherapy or surgery or whatever, can we do a little bit of tebentafusp first? And is that helpful? So that's one trial that's going on for TEBI. In the adjuvant or preventative setting, right? So after treatment of the primary, can we give a medicine to prevent the development of metastasis? There are actually 2 trials ongoing. One is being done in the UK, where they're following patients with uveal melanoma after treatment of the primary with a blood test looking for something called circulating tumor DNA, which are fragments of cancer DNA. And if we find that, then they get some tebentafusp. And then in Europe, in the near future, in the US, a randomized trial of adjuvant tebentafusp in high-risk patients will be launched. In my opinion, this would be the priority trial in the setting for HLA positive patients. At Pittsburgh, they're looking to see if they can use circulating tumor DNA to better use tebentafusp in the metastatic disease setting. Anthony Joshua in Australia is combining tebentafusp with IL-2, another immunotherapy, to see if that makes things work better. In Miami, they're combining tebentafusp with radioembolization. And then at Jefferson, in the near future, I hope they'll be combining tebentafusp with immunoembolization to see if that combination works. So I'm really going to go very quickly just through some of these data, just so you guys are aware of what's going on again. And one of the questions is, when do we do tebentafusp? Should we do it first? Should we do it later? We still use a lot of checkpoint inhibition, those anti-PD-1 therapies like Keytruda or Opdivo. And to answer that question, colleagues from Switzerland launched this really nice international collaboration to actually look retrospectively at patients who got tebentafusp either first followed by immunotherapy, that checkpoint inhibition, or checkpoint inhibition first and then tebentafusp afterwards. These sorts of studies are always hard to interpret, but this is just looking at how long the cancer was controlled. And here it turns out that they found that if you got the immunotherapy first, actually, and then tebentafusp second, that duration of disease control seemed to be better. Again, tough to interpret. I think this is something that has to be replicated in a different model and study design, but I think it's worth considering. And to me, it kind of highlights that, even if you don't get it first, it's okay to get it second. Okay. Second question, how long should you treat patients with tebentafusp? And this is an important point. This is a patient of mine earlier on. On the scan, this is like the tip of the liver on the right, and the amount of cancer was pretty low in this patient, but there's that small spot of cancer in that yellow circle. And this patient got 8 doses of tebentafusp, and then that spot of cancer grew. If this were chemotherapy, any targeted therapy, we would definitely take the patient off and say that this treatment is not helping. But with treatments like this, I strongly advocate continuing to treat and seeing what happens on the next scan. Because in this patient on the next scan, it basically just went away. And this patient remained on tebentafusp for a long time. And so the point is here for the patients and advocates and family members, for this sort of treatment, I think it is useful to consider treatment beyond that first scan that might show growth. Because sometimes the scans later show that things are controlled. So one of the questions is there any tool that we can do if the scans are not as good as we want them to be in helping us predict who's going to benefit from this treatment and who's not? Is there another tool? This circulating tumor DNA concept is one that might be useful. Again, circulating tumor DNA, it's a blood test, fragments of cancer DNA that we can measure. And on the left, you can see data that the majority of the patients that we treat have a decrease in that circulating tumor DNA, with actually 13% in one of our trials showing complete resolution of the circulating tumor DNA. But what was interesting is that decrease, even in the patients who had complete resolution, there's no cancer DNA in the blood. On the scan, some of those patients had scans that showed that the cancer looked bigger. And which was right. It turns out that the ctDNA kind of trumped in terms of prediction. So if the scans looked bad, but the circulating tumor DNA was good, the patients did well. This is another patient, kind of similar story. This is a patient who at baseline had a small liver lesion, but after 2 months of treatment, it looked bigger. But over time, you can see that things kind of basically stayed the same. So although there was initial growth, things stabilized. This patient had total clearance of the ctDNA and did really well. The point I want to make here, though, is if you look at those red boxes where that cancer is, you can kind of see that the characteristics of that tumor look different, right? It looks different. And because we saw that in a lot of cases, we started looking at, are there predictors that we can find from the scans that might predict? And there's a whole field called radiomics where we do that. We look at features of the scan, of the tumors on the scans, and look for changes in different characteristics, and we can quantify that. And that's a field called radiomics. And we did that with tebentafusp. And using these features, we could predict after 2 months of treatment which patients were going to have a decrease in the circulating tumor DNA and which ones weren't, right? So that's pretty cool. Other things we've been doing are looking at other predictors. At baseline, can we find patients whose immune system was functioning the right way so that tebentafusp would work? And this was work from Joe Sacco in the UK. He found a signature that could actually do that at baseline, which further work is ongoing. And then finally, also work from Dr. Sacco in the UK. He was looking at the tumor biopsies. We asked frequently patients to get biopsies of the liver if they're on these trials, right? And it's hard to do. I know we're asking a lot of our patients, but the information we get from that is really important. And what was found here is that at baseline, if there's a lot of this thing called interferon in the tumor, those patients tend to do well with tebentafusp. With treatment, the patients have more immune cells in the tumor, and not just any immune cells, but immune cells that are kind of younger immune cells that have this IL-7R kind of expression. Those are the patients who seem to do well. And then even when the cancer grows, if we do a biopsy, if those biopsies show that the tumor has a lot of this antigen presentation or like just immune recognition machinery working, that also seems to predict well. So again, these were those outstanding questions. Again, we're working on this. There's still a lot to do. This is a great beginning.
Thank you guys so much. So, next up, like Dr. Carvajal said, we do have Dr. Justin Moser, and he is ready to chat with us a little more about the OCUL-01 study.
Great. Well, thanks everyone for joining the presentation today, and thanks Danae and Rich for having me. So we're going to talk about the OCUL-1 study, which is a study of roganolisib. So we can go to the next slide. The OCUL-1 study is a phase 2 study that's currently being done kind of around the globe. And this is of a drug called roganolisib, which is a PI3K delta inhibitor. So when you kind of read about PI3K, there's a lot of PI3K inhibitors that are out there. Mainly, so most of these are currently approved for breast cancer. And you'll read that most of these are fairly toxic and hard to tolerate. And that's because the PI3K protein isn't actually one type of protein, it's actually a family of different proteins that all do different things. And most of the drugs that are out there hit all of these family members of the PI3K proteins, which then causes lots of side effects. Because when we think about anti-cancer drugs, we want to hit the protein that we want to without hitting the ones that we don't, because hitting the ones that we don't is what drives side effects. So as you can see on this graph here, here's some examples of some of the different um, PI3K proteins and what they do. And you see on the bottom left of this photo that for PI3K delta really, helps drive immune suppression by promoting T regulatory and myeloid-derived suppressor cells, which are cells that we know support the cancer, but it dampen the immune system within the tumor. And it also blocks dendritic cells. And this goes back to that antigen presentation machinery that Dr. Carvajal was just talking about. Dendritic cells are really the cells that take up cancerous proteins and tell the immune system, hey, this is what we need to fight against. This is how you recognize the cancer. And so roganolisib is a PI3K delta specific inhibitor that truly is specific and only targets the delta isoform of this protein rather than all the other ones. So it is far more tolerable than the other PI3K inhibitors that are out there. In the phase 1 study of roganolisib, which was presented at ASCO in 2023, and this was a phase 1 study done in Europe, they treated a handful of patients with uveal melanoma. And while they didn't see any responses in terms of the images showing the tumor shrink, what they did show is many patients had their disease stabilize. And in their small expansion arm, which I believe was 20 or 30 uveal melanoma patients, for patients with refractory disease, they saw an average survival of over 2 years, which is on the order of what we would expect with frontline treatment with either, Kimtrac or Hepzada, which have been published. And so that was really exciting to be able to see tumors that were growing and have them stop growing and stabilize for years. And so that has spurred a randomized phase 2 study, which we'll talk about. Because the drug is so specific to this one form of PI3K, it actually was very well tolerated. Only 10% of patients in the initial phase 1 trial had a clinically significant side effect. So this drug was very tolerable, very little side effects, and stabilized disease for a long time. So that launched the OCUL-1 study, which is a randomized study of 3 arms looking at patients with refractory uveal melanoma. So patients had to have been treated with at least one prior line of immune therapy, and that it could be any immune therapy. It's very broad. It could be a checkpoint inhibitor, it could be tebentafusp, may even be an immune embolization, but I don't know that one off the top of my head. But it's very broad and inclusive, which is great for our uveal melanoma patients. And patients do have to undergo a biopsy so they can better understand how this drug works. And once patients are randomized, they're randomized to get either investigator's choice, which is pretty wide open in terms of what you can give. There's not a lot of restrictions, or 2 different doses of the roganolisib drug, which here is called IOA-244. Initially, there's 2 different dose levels of the drug because that's an FDA requirement. You have to prove that one dose is better than the other. Once the third arm of this study is fully accrued, then it'll just be randomized between the first two arms, arm one and arm two, in a 2-to-1 fashion, where you're twice as likely to get the roginolisib or IOA 244 drug as you are investigator's choice. So this is a great option for our refractory uveal melanoma patients. As we know, a lot of the uveal melanoma studies right now are really in the frontline setting and restrict prior liver-directed therapies or radiation, where this one is second line plus and doesn't restrict any of that. And it is currently enrolling in Italy, Spain, the UK, and then currently here in Scottsdale, Arizona. I believe other sites in the United States will be opening up shortly, but currently, I believe we're the only site in the United States.
Awesome. Well, Dr. Moser, thank you so much for sharing this about the Ocular One study. I think this is probably one of the more exciting, like newer trials that I've heard about in the last year or so. So this is really exciting that we have this here. Next up, we have Dr. Cam Montazeri. So I'm going to go ahead and bring her on stage.
Thank you very much. Awesome talks from my fantastic colleagues. Great work being done in this space, which is wonderful for our patients. So I'm going to talk about one of the clinical trials that is up and running, basically one of the medications that is in clinical trials and a few clinical trials, currently in 2 clinical trials in the metastatic setting. The drug is called darovasertib, not an easy name, or ID 196. It's basically a drug that's designed to target and inhibit a protein called protein kinase C, which has a role in growth and basically in division of the cells and replication of the cells. So blocking this protein may help slow down the progression of the disease, or maybe stop the progression of the tumor. Crizotinib is another drug that blocks a protein called MET, which is highly expressed in uveal melanoma cells. And these 2 medications are both oral medications. Darovasertib is a twice-daily medication, and crizotinib can either be twice daily or once daily, depending on the dose that we want to give to the patients. The first clinical trial that I'm talking about briefly is a study that's currently in the phase 2-3 of the clinical trial with the combination of darovasertib plus crizotinib or investigator's choice, which usually is standard immunotherapy. Dacarbazine is one of the other choices that we rarely use in this setting. So mainly either standard immunotherapy or darovasertib plus crizotinib. It's a randomized study, 2-to-1 randomization to either the study arm or the standard of care arm. And the aim of the study is to look to see how well these treatments work in slowing down the progression of the disease and improving survival outcomes for the patients. And the patients who join the study are basically randomly assigned to either receive the darovasertib crizotinib combination or usually standard immunotherapy. This study is a frontline study. So basically patients who are newly diagnosed, they are HLA-A*02:01 negative, meaning that they don't have the option of receiving tebentafusp as the standard of care option. They have option of going to clinical trials, and this is a frontline clinical trial for those patients. So basically, these patients get randomized and get either the study drug or the immunotherapy drug. And the primary end, as I said, is to see if it can slow down the progression of the disease. In terms of the side effects, well, these are newer drugs and we don't have all the side effect details from them. Things that are more common and more predictable with targeted therapy drugs are some GI side effects, like diarrhea or constipation, nausea, vomiting, sometimes skin reactions, like rash, sometimes basically fluid retention and like swelling, which patients usually need supportive medications to prevent or to control these side effects. Other study with this drug is called ID 19601. The previous one was 02. This is for patients with solid tumors that harbor GNAQ or GNA11 mutation, including uveal melanoma cells that usually have this mutation in the metastatic setting. And I apologize that this is blurry, but this is for patients that have received previously melanoma treatments, including patients that are HLA a O201 positive and have previously received tebentafusp, or for some reason they are not candidates for tebentafusp, and it's currently recruiting in the US and in some other countries.
We do have time for some questions right now. Okay, so it says any clinical trial using Tebi interswitch with nivolumab and ipilimumab. So I think that's the question, is like, are there ones where you can switch back and forth?
Yeah, so this is kind of a sequencing question. I'm not aware of any true sequencing prospective trial. It's a super important question. You know, that prior trial that was led by the Switzerland team, what was done there is they asked all of like 14 centers, of all of your tebentafusp patients, did they get checkpoint blockade before and after? And we put all that data together. So I suspect that may be the way that we have to do this. Like we have all these anecdotes. Like we've tried to look at sequencing even on the clinical trial patients. Like our trial patients on tebentafusp, if they got checkpoint blockade after, how did they do? And we have these anecdotes I used to talk about a lot where patients got checkpoint blockade first, and then the cancer grew, and then they went on tebentafusp, and then it worked for a while, then stopped, and they went back on checkpoint blockade, and then the checkpoint blockade worked again. And that does suggest that in those cases anyway, something is changing in that microenvironment to make checkpoint blockade work. So I love the hypothesis, looking at T cell exhaustion and PD-1 upregulation. I think all of that is kind of true. I could go on and on. I guess the point is that we don't know. I don't know, Justin or Cam.
I agree. I think we don't, it's a fascinating question, and I would love to understand the immune system enough so we could like make these rational accommodations. I think though, when the thing to remember, whenever we're talking about drugs like nivolumab and ipilimumab or other checkpoint inhibitors, the half-life of these drugs are, weeks, if not a month. But also we know from the phase 1 studies that although they're out of the blood in about a month, they're still bound to the receptor 2, 3 months later. And so if you give someone nivolumab and ipilimumab and 2 months later you give them Tebi, they still have that on board. That's still there. And so these drugs hang around so long that, switching back and forth and sequencing is probably less of an issue than drugs that are like pills that are only in your body for a couple hours.
It's very important to do more work on understanding the tumor microenvironment that changes with tebentafusp and drugs like basically immune engagers that is different from immune checkpoint inhibitors. So there are a lot of exciting work coming out of these basically lab research based on these patients and the samples that we have that have generously been donated by the patients that have been treated on tebentafusp.
And have we said, just for clarification, Tebi or tebentafusp is also the same as Kimtrac. So if you hear those being used in the office, Kimtrac is the brand name, Tebi is the drug name, like the scientific name of the drug. So they are used interchangeably. Most of the time, doctors seem to refer to it as tebentafusp for us as patients, but you're going to see the branding Kimtrac. So just know they're the same thing. Okay, we've got 2 more questions, and one of them is, do you know if any research centers are looking into using mRNA or CRISPR for uveal melanoma?
I'm assuming by mRNA, you're talking about the vaccines.
I think it
And
sounds like a
I know
vaccine.
there are,
Yeah.
yeah, I don't think anything is up and running. I know Jose Lutsky at University of Miami is working on something. I think in the adjuvant setting, we have applied for a grant to use not an mRNA vaccine, but a protein-based vaccine in uveal melanoma. So if that grant gets funded, hopefully that will be available by the end of the year. I think there's a lot of excitement around these things. And all of us are trying to get them in this space, but I'm not sure they're there yet.
All right. Awesome. Okay, the last question that I'm seeing right now is showing I will come off the IDE trial in 2 months, 6 months post-brachy. So it sounds like this patient was doing the kind of adjuvant or neoadjuvant setting of the IDE. Does that sound correct, Dr. Montazeri?
I believe so, yes, based on what they're.
Okay. So then he's asking, is there another trial that could be available for me to join to protect from metastases? So he's still no mets, but looking to do kind of an adjuvant therapy. I guess, Chris, this will probably be something that we'll address a little later when we cover the adjuvant setting. You guys good to cover this a little later?
Yeah, but since I don't know if they're going to be, just to briefly mention that, as you know, the standard of care is still just doing radiation therapy and monitoring. And it's great that you, hopefully benefited from this. Unfortunately, in the adjuvant setting, we don't have any studies that come, as the second line or for patients that have previously received any adjuvant therapy.
Okay, this is actually, I know we're kind of hinting a little at some of the adjuvant, but I think it is important to recognize that we can address this here. This question says that diagnosed recently in June with choroidal melanoma, had plaque brachytherapy in the July time, and just waiting on genetics. Once I have these genetics, do I need to wait for metastases to happen, or can I start immunotherapy or one of these drugs based on what my genetics show?
Yeah, and I think we should be careful. Like, I don't want to be giving kind of personal medical advice on
Yeah.
online. But this actually definitely falls under the adjuvant session.
Yeah. Okay. So Tina, we'll cover back. We'll keep your question, and we will cover this in the adjuvant setting when we talk about the adjuvant, meaning pre-metastatic. So before anything happens in the rest of the body. This one is a question from Jim Diario, and it says, "Do you see promise of using Anktiva N-803 to supercharge the immune system's response to cancer? It's a modified interleukin 15, and I'm wondering if it will ever be used for metastatic uveal melanoma."
Maybe. I mean, there's so many promising strategies. I think the question is, which ones do we kind of take for a dedicated trial for uveal melanoma? It's a huge struggle. One of the slides that I had, Danae, that I don't think we'll go through is kind of the list of kind of the active trials. There are actually a ton for the kind of metastatic disease setting. So even if we're not looking at IL-15 currently, there are a lot of other ones that are really promising.
All right. Well, then I think we're going to wrap up this section of the Q&A. With that, I've got your slides ready to go, Dr. Orloff, and thank you so much for joining us.
Thank you so much, Danae and Akira Insight for having me. And hi, everyone who's listening live. And probably, I think this is being recorded, so folks who may be listening at a future date. So I've been asked really to discuss the RP2 Replimune clinical trial as part of under the umbrella of regional therapies in metastatic uveal melanoma. So I know there was just a session on more systemic treatments, and I would actually argue that RP2 probably could fit in both categories. So I could have spoke in the last session, but certainly it also fits in this category as well. And I'll kind of go through some slides kind of explaining why I think of RP2 as both kind of a regional therapy, but also a systemic therapy. I think you have already, got quite a nice background on uveal melanoma. But the thing to remember, I think, going into this session on local, regional, or liver-directed therapy is that, we know that despite uveal melanoma being a metastatic disease in which, cells are likely floating all around, about 90% of patients will present with liver metastasis at least first, and the majority of patients having liver metastasis at some point in their disease course. And still, really, most patients succumbing to liver failure as part of the end stage of the disease. And so, addressing the liver, working on treatments that treat just the liver are obviously an important part of our toolbox. To kind of then talk a bit about metastatic uveal melanoma as a target for immunotherapy, you, I think, heard in the last session a bit about why immune checkpoint inhibitors, such as CTLA-4s and PD-1s, Yervoy, Opdivo, may not be the best choice as compared to cutaneous melanoma, and that metastatic uveal melanoma is historically what they call cold tumor, not really responding well to immunotherapy, somewhat in part by the fact that the primary site is the liver, which is kind of a hard nut to crack. Also because we know things about uveal melanoma, and that just genetically, it's kind of a bland tumor. So it doesn't have many mutations. It doesn't look super foreign to the immune system. So even if you rev the immune system up, sometimes that's not enough to kind of get the immune system to recognize it and kill it. So really what RP2 is a approach that kind of bridges both of these concepts. One, We know that the tumors like to go to the liver. We know that we need to control the liver. And then also we know to try to address it from an immunotherapy standpoint. It's not as simple as just kind of waking up the immune system. We need to do something that's a little more targeted and specific. So, you know, what RP2 is, and sorry, it's the slides are a little blurry on my side. I'm not sure if they're blurry for you. But so you can't totally read the fine print, but RP2 is really a genetically modified herpes virus that encodes these other kind of immunostimulatory things like GM-CSF, something called Gal-VGPR, and CTLA4, which you've heard about. And this is actually injected directly into the tumor. So it's in a class of drugs called oncolytic viruses. This is not the first oncolytic virus to be tested. There is actually one that's already FDA approved for cutaneous melanoma, something called TVEC, which is basically a modified herpes virus plus GM-CSF. So this is kind of a tweak on that. And the principle is you can inject it into the tumor. It preferentially replicates in the tumor. And when viruses replicate, it can kind of cause the cells to essentially explode, kind of spill their cancer guts out, which can be very immunogenic or really can wake up the immune system. And then in this trial, it's combined with immunotherapy to then kind of, you know, have that extra boost. This is just a snapshot of the prior clinical trial. So there was a kind of a phase 1/2 trial of RP2, and RP2 is just part of the larger Replimune platform. There's RP1, which is really tested in cutaneous melanoma, and there's actually RP3. But this was RP2, and it enrolled actually, I think, melanoma all comers, but including uveal melanoma. And you can again see here that there was patients who in cohort 2A were treated with combination treatment. And it is an injection that's every 2 weeks times 8 doses. And then that's in combination with nivolumab. And then there was also an expansion cohort, as you can see there. So here's just a snapshot of the uveal melanoma patients that were on the trial. Not, you know, a ton of patients, 3 patients receiving just RP2 monotherapy and 14 receiving the RP2 plus nivolumab. You can see here that the majority of patients did receive prior immunotherapy, and a good portion of them actually even received greater than 3 prior lines of therapy. So this was really a pre-treated patient population. And if you look across here, really just going down to overall response rate, we actually see that patients, again, very few patients in the monotherapy arm, but 14 patients in the combination arm, the response rate about 28% with a disease control rate of 64%. So again, overall response rate 29.4%. So, you know, again, in uveal melanoma patients, many of which who are pre-treated, prior immune checkpoint, this was actually a pretty good response rate. You know, you heard a bit about tebentafusp, which is our other immunotherapy that's approved in the space. And while in a randomized trial, tebentafusp does show an overall survival benefit, we know that the response rates, even with tebentafusp, are quite low. So this is actually a higher true response rate shrinkage of tumor that we've seen before with other immunotherapies. And then just there on the right, just showing that responses were observed in patients who are A201 positive and negative. What is not kind of teased out here are patients who had previously gotten tebentafusp necessarily. I only showed patients, the proportion of patients who got prior immune checkpoint. And here's just a swimmer's plot, just showing that there was a number of patients, especially patients who had, say, partial response, who went on to have response for quite a while. And then here's just a few examples of patients who were treated on the trial. So I did mention that there is a drug, oncolytic virus, that's already approved in cutaneous melanoma, something called TVEC. And really that treatment, when it was tested and approved, was really in superficial lesions. So skin lesions that you can see, lymph nodes that you can feel. And though there had been subsequent clinical trials looking at TVEC to be injected viscerally, that's not really what the intent was. Viscerally meaning kind of like deep into organs. But the Replimune and RP2's approach is very much to inject medication viscerally directly into the liver. So that's really what you're seeing here on the left side, starting at screening, tumor in the red. And so that's an injected lesion. And what we do see here is that even patients who have tumors that maybe aren't injected, they will still have response. So here you can see only one tumor was injected, that's in the red, and you can see that shrinkage over time, but you can also see uninjected, the lesions that are around with yellow, also shrinking over time. What this doesn't necessarily illustrate is, perhaps there's also a lung lesion that wasn't injected that could, respond. So that's why, when I started off this talk, I mentioned, while we think of RP2 as a local regional therapy, there's definitely the potential. And obviously also because it's going to be tested in combination with nivolumab, which is a systemic therapy, but we can definitely see response in uninjected lesions. So it's not just if you concentrate your treatment in the liver, you're only expecting to see liver response. You can certainly hope for and see response outside the liver. And here again is another liver snapshot. Again, a patient who got RP2 plus Nivo, previously progressed on Ipi-Nivo, having response in injected and uninjected lesions in the liver. And lastly, just want to round out that based on that data with those patients in that initial trial, there is now a randomized trial that is enrolling. So important to note, as I'm sure you've heard from the other folks, that, this isn't a trial that's going to be an option for everyone. And that is because it's specifically for patients who are immune checkpoint naive. So if you've previously had an immune checkpoint inhibitor, you're not eligible for this trial. And that's because really it randomizes to Ipi-Nivo. So you can have had less than or equal to 1 prior line. And you cannot have had prior liver-directed therapy. So what that really means is patients could have had prior tebentafusp if they're A201 positive and come on this trial, or actually patients who are A2 negative who perhaps were enrolled on the IDEA trial that was previously discussed. If they were randomized to the darovasertib crizotinib arm, then they could come on here. But you can imagine if you were A2 negative and randomized to the Ipi-Nivo arm on that other trial, you couldn't come on to here. So that's important to note. There also are some exclusion criteria based on liver functions, as well as percent liver involvement that have to be considered. But it was really just that, again, it's a randomized trial and those are the endpoints. And this trial is open at a variety of sites now globally.
Awesome. Okay, well, thank you, Marlena. That was wonderful. And this has been a trial that I have been following since I found Replimune in ASCO in 2022 as a patient advocate. I ran into them at one of the booths and I was like, oh, what are you guys doing? Do you know about uveal? And they were like, actually, yes. So it's really neat to see this go from kind of its inception to it's now in study. So that's really neat. I am so glad that we were able to chat about this. Next up, we're going to have Dr. Justin Moser, who's going to be covering Hepzato.
Thanks everyone for having me back, and great presentation, Marlena. So Hepzato, as everyone knows, is currently one of the 2 FDA-approved treatments for uveal melanoma, and that means treatments you can get outside of a clinical trial. There's the Kimmtrak, tebentafusp, or Tebi that Dr. Carvajal talked about, and then there's Hepzato. And Hepzato falls under these regional therapies because it treats the liver, but it treats the whole liver, which is very different than a lot of the other liver-directed therapies like ablations, histosonics, which Kevin will talk about, embolization. Well, embolizations can treat the whole liver too. It depends how you do them. But what this is a procedure that's done under full anesthesia. So you go into the interventional radiology suite or the OR and you are completely put out just like you're having surgery. And then what happens is the interventional radiologist or the surgeon will put lines in kind of all 4 corners, one at each groin and then one in each side of your neck. And they use those lines, as you can see on the picture over here, to really isolate the blood supply of the liver and to put it on its own blood circuit. So you can see on the photo that, there's this blue line there that takes the blood from the liver and goes through this filtration system. So it kind of puts the liver on bypass, just like we put the heart on bypass when we do open heart surgery and stuff like that. Once the liver's on bypass, they inject high doses of chemotherapy, something called melphalan, into the liver. And the doses of melphalan that we give are doses that are similar in size to what we use for bone marrow transplant. So if we would give this level of chemotherapy through an IV, it would completely kill the bone marrow and you would have to get your own bone marrow back or someone else's bone marrow back as part of a bone marrow transplant. And we don't want that. We don't want all those side effects here. And so what they do is they give that similar amount of melphalan directly to the liver, but because they put the liver on its own blood circuit, instead of that chemotherapy going everywhere in the body, it goes and circulates through the closed loop that we put the liver on. So that chemotherapy will circulate through the liver for about 30 minutes. And then they do 30 minutes of filtering that chemotherapy out through the filter. And these filters will take about 90%, I think it's a little higher than that actually, of the chemotherapy out of the blood before it gets returned to the body. And using this circuit, what we can do is we can actually give massive doses of chemotherapy to the liver to kill the cancer without causing significant systemic side effects like, chronic bone marrow damage, hair loss, and stuff like that. After the procedure is done, the lines are all removed. And in the trial, initially, patients spent one night in the ICU just for observation to make sure there was no issues, and then they were discharged home. I think as we're gaining more experience, we're seeing more institutions do this, maybe not in ICU, but maybe on the floor. And that will probably change with time. But in the studies, everyone was monitored in the ICU for one night. This is not a one-time treatment. This is done every 6 weeks, and it's done for up to 6 treatments as long as it's working and not causing any side effects. On the study, the average number of treatments was about 4, and that was because either the patient's cancer progressed or they developed side effects with low blood counts. Now, the thing about the Hepzato is we know we're only treating the liver. So this is really a good option for people who have liver-only disease or liver predominant disease and have minimal disease outside the liver that we can control another way with radiation or ablation or something else. Because obviously, treating the liver here is not going to help treat any mets that would be outside of that. This is different than hepatic perfusion. I have had some patients ask me, well, other people do hepatic perfusion, but you can only do it one time. And that goes back to how this is done. Before this was approved, there were institutions that did hepatic perfusion very similarly, but it was done via a surgical method where they would go in there and surgically open up the blood vessels and do this. When you do it via surgery, you can only do it one time. The real novelty of Hepzato is that we do it percutaneously, which means through the skin and not through a surgery, which allows you to do it more than one time in every 6 weeks. So this was FDA approved in 2023 based on the FOCUS trial, but it's actually been available in Europe for a couple of years earlier, 2 to 3 years, I believe. And so there's a lot of experience of using this type of treatment, despite the fact that it is still relatively new in the United States. It was approved based on a phase 3 trial, the FOCUS trial, led by Dr. Zager at Moffitt. And what this was is it was initially a randomized study of percutaneous hepatic perfusion versus standard of care, but it was eventually changed to just be a trial, a single-arm trial, because there just wasn't great best supportive care at that time. When the time this trial was going on, we didn't have tebentafusp or any of the other things that we've talked about today. And in the trial, you had to have, predominantly liver-only disease, preferably. I believe they did allow some patients who had extrahepatic disease that was treated with radiation. And what they showed is that there was a 36% response rate, meaning that 36% of patients had their tumors shrink on scans. But I think now that this is FDA approved, what we're seeing is that it's more patients are benefiting than just 36%. And I think it goes back to what Dr. Carvajal talked about earlier with tebentafusp, which is on that study, they saw only a 9 to 12% response rate, but we saw more patients benefit. And when you look at circulating tumor DNA in that study, that seemed to correlate better with who was benefiting from treatment rather than scans. And I think we're learning that that's probably true in uveal melanoma with liver mets in general. And so, clinically, now that we're using this, I think we're seeing more than 36% of patients have reduction in circulating tumor DNA. When the interventional radiologist actually does this treatment, they do an angiogram before the treatment, and they're seeing far more patients have changes in the angiogram, which correlates with the tumor's response than 36%. And so I think this is actually benefiting more patients than that. It's just we're learning over this past year or past couple of years, what is the best way to follow patients in terms of deciding who's benefiting? And I think we're all learning MRI and CTs may not be the best. It may be circulating tumor DNA or angiograms or other things. On this study, they did find a median duration of response of 14 months with a median overall survival of, I think, just about 2 years. So similar to what we saw for tebentafusp in their randomized frontline study. This is unfortunately only available at certain centers because of how technical this is. It does require a specialized team. You need the machinery and the device to do cardiothoracic surgery, to do bypass on the liver. You need interventional radiologists, you need perfusionists, you need anesthesiologists, and you need a medical oncologist that sees uveal melanoma. And having all of those parts under one roof is not all that common. So here's a current map of the centers that where Hevzato is currently available. You see on the East Coast, kind of Midwest to East Coast, this is fairly heavily available. However, when you look more west, it is more limited. And so this is something you may have to travel for, especially if you live kind of west of the Mississippi River. But thankfully, it is something that's only done every 4, sometimes up to 8 weeks. So it is something that can be accommodated if needed.
Thank you, Dr. Moser. Before we bring our next speaker live, we've got Dr. Kevin Burns on here. Dr. Carvajal, I wanted to give you a sec to give us an explanation for okay, histotripsy. I know it's kind of a little bit of a buzzword, but also a little bit of a controversial topic. And I know that you were the one who brought this up to me, even though I love histo because I just do. But go ahead and just explain to our patients, our population, why are we even talking about this today?
Well, histotripsy, first of all, and you'll hear from Dr. Burns how novel this technology is. This is something that it's been a long time in development, and it's just a really novel way to do tumor ablation in the liver, ultimately the kidney and elsewhere as well. I always caution people regarding becoming a little bit over enthusiastic with some of these new treatments, whether it be systemic, anything, because this has happened to us time and time again. Where we think, wow, this is it. This is going to be the cure. And unfortunately, in more cases than not, it's not as good as we hope in the beginning. I am not saying that's the case, for anything we're talking about here, but I just urge that people be a bit cautious. Histo is very cool. This is another ablative type therapies you'll hear about, I think. And Dr. Burns, I don't want to steal your thunder at all. But one of the questions will be, where does it fit in our other kind of ablative or regional therapies? Where should it be used? Is it really better or less good than other therapies? I think there's a lot we still have to figure out.
Yeah, for sure. Okay, well, Dr. Burns, I'm going to give you leave to share your slides so we can make sure to share any of your interactive parts of the slides.
So I'm Dr. Kevin Burns. I'm an interventional radiologist. So as Dr. Moser was mentioning before, if you had Hepzato, we'd be kind of the physician performing that procedure as well. So you may have met somebody that does the same procedure if you've had a biopsy of the liver or any other organ. So we kind of do a lot of things around the body using imaging guidance. In this case, with this procedure, we're using ultrasound guidance. And just disclosure, I am a consultant for the only company who makes this device, but I'm not speaking on their behalf as part of this talk. So histotripsy is a new mechanism of action to destroy tumors, and so this is a mechanical destruction, which is different than other therapies that we've talked about. So microwave ablation, cryoablation, those are thermal, so it uses heat or cold to kill things. You can have radiation, which obviously uses radiation. That would fall under also Y90. You can do embolization as well, which kills with ischemia, but this is a mechanical destruction. So it really liquefies the tumor in a mechanical process. And so that means that whatever is treated with histotripsy is instantly killed, and we can have very precise margins, which is different than some of the other therapies where you have a gradient, where maybe the center is killed and there's a marginal recurrence because the treatment wasn't uniform. And so this therapy can be very precise, meaning you can get very close to other structures without damaging them. It also has some tissue selectivity, so structures that are made of more collagen. So think about the capsule of the liver, a bile duct, a blood vessel, which is an artery or a vein, are actually spared by this treatment. And so you can treat maybe a tumor that's in a more complex location where you wouldn't be able to offer a thermal ablation. Oh, this is kind of what the treatment head there's only one commercially available device for this right now. So this is kind of what the treatment head looks like, and kind of in this depiction, think about this like a satellite dish basically, and it's sending all these ultrasound beams, and then they meet at one point, which you can see kind of at the bottom of the screen there, which is depicted as the bubble cloud. And so this means that anything in the near field, meaning between the treatment head and the bubble cloud, there's no damage to the tissue. So you could turn this on in water, for example. You could put your hand under this while it's on. You wouldn't feel anything. Obviously, if you put your hand at that focal point, you would have histotrypsy happen, but there's no damage to the near field or the far field. So that differentiates this from radiation, so it doesn't have a lot of the toxicity of an entry or exit dose from that standpoint. Patient-wise, this is non-invasive, but this is also done under anesthesia, similar to Hepzato. And so this is done basically like in an operating room, like you're having surgery, but there are no incisions at all. This is not even a sterile procedure, so there's no prep that's done. As you probably have known, if you've had an ultrasound before, you put all this ultrasound gel on the probe before the ultrasound tech would scan you. That's because ultrasound waves don't really transmit through air. And so we have to kind of figure this out as well with histotrypsy. And so there's what's called a water bath. So this large, basically tub of water is put on top of you, kind of over where we think we're going to be doing the treatment. And then this treatment head goes inside of that water. And so that we can deliver the energy directly through a liquid into your body. So is that playing? Yeah. So it's just a simulation of kind of what would happen internally. And so this little depiction here is a tumor there. This is the console that the physician uses. So this uses live ultrasound. So during the therapy, we try to find the tumor with ultrasound. We can kind of plan out how big we need the treatment to be. And then, the amount of power needed to treat a tumor in each tumor location, and each patient is different. So we calibrate that. And then the treatment kind of is guided electronically as well as kind of robotically through this. So we program everything out. The real reason you need to be asleep is you can't move at all really once this starts. And so that we make sure that there's no movement internally, so we can make sure we're treating the area that we kind of prescribe. This is just a simulation of the bubble cloud going through the tumor, which is kind of liquefying the treatment cavity. And so this is kind of what the water bath would look like here with the treatment head inside of it delivering the therapy. Multiple tumors can be treated at any one time. This is more focal therapy, so it's not a systemic, or it's not a complete liver treatment. Thinking about like Hepzato, this is more of a focal therapy, so would be similar to someone who may get SBRT or radiation. SBRT or microwave ablation, where we're targeting a single tumor, so you can treat multiple tumors at once. This is kind of a pathologic images of what's happening internally. So let's say a tumor was treated and then immediately it was excised from the body so that we can see what happened. In the center, you can see this pink, that is the lysate. And so that is just broken down contents of cells. There's no actual viable cells in there. And you can see the other cell in this magnified view, the stuff that's more on the bottom left edge, those are kind of the normal cells. So you can see the difference. And then there's this very sharp margin where the treatment kind of stops. And so if you looked at either, a sample with radiation or microwave ablation like this, there'd be a very long, very big transition zone, but there's going to be a mixture of viable and non-viable cells. And so I think this kind of shows this very well demarcated treatment zone in this, and also this central zone that doesn't really contain any cells. That means if you just gave a pathologist the center of this, they would not be able to tell you what it is. We were talking about tissue selectivity earlier. And so these are just some examples in testing. It shows in that left image, there's a large blood vessel in the center there that's right in the middle of the treatment cavity. As well as in the central image, you can see these ducts and blood vessels that travel right through the treatment cavity. And on the kind of the right side of image, that is a video, you could play that. It shows like kind of the structure of the liver. If it doesn't work, that's okay. The structure of the liver is kind of preserved, whereas everything else that was cellular was liquefied and removed. And this is just another picture of kind of what would be touching you during the therapy. And so this is the water bath that goes on here. There's this flexible membrane. You actually get kind of rubbed down with oil in order to create a better contact between this membrane and your skin. We talked about kind of air before, so that means that there's going to be some limitations on locations where we can treat. We do need to be able to see it with ultrasound, and we can't treat through the lung because that is filled with air. And so there's going to be some limitations. So, if you know the different segments of the liver, the, segment 2, segment 4A, 7, and 8, those are kind of the top of the liver. We do treat those segments, but if you have a tumor that's on the very top of one of those, that may mean that it's not a good candidate for this procedure because we may not be able to see it without going through the lung, which is air, and that would kind of block all of this energy from going through. You can go to the next slide. And so kind of just looking at, there's some trials on this. This is new, obviously. So the Hope for Liver trial was the study that helped get this approved. Looked at about 44 patients. This is specific to all tumors. This wasn't, a uveal melanoma trial, but they basically just looked at whether this procedure was safe and effective. And this is done internationally as well as in the US. And you can see in the breakdown of tumor location or tumor types, most of these were metastatic disease, and there were 2 uveal melanoma patients in this trial. And so this procedure showed that there was a high technical success. So 95% of the tumors were able to be targeted and correctly treated as determined by an MRI that was done immediately after the procedure. And so they met their, efficacy goals with this. You can go to the next slide. So there's also a safety trial. This looked at, the rate of complications here. So overall, very low rate of complications, and most of them were minor if they occurred. One patient did have an infection. One patient had some pain. One patient progressed to having liver failure. Again, these patients in this trial were all very ill. They weren't actually allowed to be on any systemic therapy, or they had to fail therapy. And so there was one patient who did pass away about a month after the procedure, but they had a very heavy disease burden. I wanted to show this, in case you've seen your MRIs, if you're having liver-directed therapies. And so these are 2 different patients who are part of the trial, and so they have follow-up on these patients out to 2 years. So on the top, you can see this very small white dot in the liver. That is a small lesion. It was treated with histotripsy, and the second image on the top row, you can see kind of this big black circle. And so that's the histotripsy zone, which is larger than the area of the tumor, because we want to get the tumor plus a margin. And as you kind of go out to 1 month, 6 months, and out to 2 years, you can see that the treatment cavity really involutes or really shrinks down. So this can make some follow-up a little bit easier compared to other therapies like microwave ablation or radiation, where there's really just a lot of kind of scar tissue and it kind of just stays there, especially if you've seen images of a microwave ablation. It really just looks the same. This can make it a little bit easier to follow. You can also see that we're not causing a lot of liver damage because there could be regeneration or just reabsorption of this cavity. And then the image on the bottom, again, is just a different tumor that was treated as well. And so the 1-year data for this came out, and this showed 90% local tumor control at 1 year. So that's the main point of this slide, and that is similar to other local therapies. And again, overall was a very safe procedure. We published as part of this study, this looked at kind of the first almost 300 patients treated in clinical practice. So that other part was a trial. This is in real life. And this was basically just to show if this procedure was safe or not in real life. And so as you can see, this about 300 patients treated, and 95% of these had no complications at all. So overall, very safe procedure. And again, this looked at a lot of patients, mostly metastatic disease. If anyone wants to reference this later, we don't have to go over this in detail. Just comparing, histotripsy, this kind of fits in with the focal spot treatments, let's call it. So that would pair it up with SBRT or microwave ablation, or even potentially Y90 if done, for a small portion of the liver. And so there are going to be some benefits and disadvantages to histotripsy. One can be location of the tumor, size can be a limitation for some focal treatment. So if you have a very, very large tumor, even microwave ablation, SBRT, those are going to be not good options as well. I think there is a lot of talk about, immunologic benefits of this procedure. I didn't include this on the slide just because I don't have like good human data related to uveal melanoma on that yet. But this therapy is not thermal and it's not radiation. So the process of killing the cell is a little bit different. And so, in animal models, and there's a lot of study on animal models in this, that's how this stuff is kind of teased out first. There are immunologic benefits where patients can have immunologic responses and with potential response in non-treated tumors. And so that does happen in kind of the lab when they're working on this. And we kind of have to have some larger study where we can actually look at this in humans, maybe potentially pairing this with some sort of immunotherapy to see if we can enhance it. But that is a potential benefit to this procedure that probably does not exist with these other therapies that are on this chart. And I think I'll end there.
Thank you so much for being here and for participating. All of you guys who are live and listening, we're glad that you are here with us. We're going to actually move into a short Q&A session.
I think what might be interesting, Danae, is maybe to just go around the room and think about how we, when do we consider doing regional therapies or ablative therapies versus systemic? I bet you there are going to be a lot of, different practices.
Yeah, for sure. I think that's a really good question because, as a patient, that's always the kicker, right? Okay, I have metastatic disease. Why should I do a trial first that's systemic versus doing liver-directed therapy? And I mean, it's such a nuance. I'm gonna kind of round table this. Dr. Moser, do you want to go first?
Yeah, so that's a great question. And I think, I mean, my number one approach in terms of sequencing therapies is keeping the toolbox full. So right now, where we have two randomized phase 3 studies that restrict liver-directed therapies, I try to do those first. And that's just because then we always have the local therapy on the back end, but we don't have those on the back end if we do local therapies first. So it's really just kind of keeping the toolbox full. Now, but that depends, right? If someone has disease that I think is growing very quickly, we need something that's going to hit it hard. So if they have fast growing disease throughout the liver, but less than 50%, I'll bring those people straight to Hepzato just because if they're growing fast, we know the response rate to combination immune therapies may be around 10%. We probably can't risk randomizing to that. In terms of the non-whole liver local therapies like ablation and stuff like that, if someone just has one lesion, and I think they're growing slowly, meaning that, they present maybe 4 or 5 years after their enucleation or plaque brachytherapy, sometimes we will try a spot treatment. Now, the tricky thing is when we do MRIs on patients with uveal melanoma, there's usually microscopic disease throughout the liver that we can't see. And even if the MRI doesn't show it, when you talk to liver surgeons who will go in there and do it, they'll say there's disease throughout the liver, even if the MRI doesn't show it. And so I really do the non-whole liver local therapies for patients who have a symptomatic lesion or two, where we could treat that. Or if they've really proven that their disease is slow growing and they can't go on treatment because there's a life event, right? They want to go on a big cruise to Europe or something like that. Sometimes we will do those spot treatments, but really it's tricky because you want to keep all the options full, and some trials will restrict it. And for most patients, unfortunately, there is more disease there than just what we can see on the MRI.
Dr. Montazari, do you want to go ahead and give your feedback?
I agree with Dr. Moser. I think that for our patients, we have to think about multiple treatment options lined up because unfortunately, this is a disease that we haven't been able to cure it or have complete response in many situations. So you have to think about what next? If this doesn't work, what next? For patients that are HLA-A*02:01 positive, I always think that we have data from a medication that has survival benefits. So even though if they have very limited disease, if there is no reason from the patient's side or my end that the patient cannot receive tebentafusp, I either do both treatments if they have a life event. I agree that there is, an option to do localized therapy and give them the benefit of disease control and send them to basically do whatever they need to take care of and then come back and continue on tebentafusp. Sometimes we start with systemic therapy and we have to add liver-directed therapy. And it has been actually most of the cases. It's just that to hit the cancer hard, especially in the liver, we know that we need both systemic and liver-directed therapy. And in real life, most of us get into a situation that sometimes we do that. And we have some data collected that hopefully we're going to get published that on the combination of tebentafusp and liver-directed therapy with the hopes that we can help patients benefit longer from that systemic therapy. In terms of the differences in local liver-directed therapies, as Dr. Burns mentioned, there are other exciting treatments coming up, but we don't have any data yet on histotripsy and the benefit, hopefully in the future, the combination of that and immunotherapy, combination of different systemic therapies could help us understand better. Obviously, we have to have hopefully some information on the tumor environment and see what happens with liquidifying the tumor. I'm still careful recommending that to our patients and who is the best candidate for those, but obviously that's another exciting option that's going to be studied further in the future.
So from a patient perspective, if you are somebody who, say, has had Hepzato, which is the whole liver chemo administered treatment that we talked about with Dr. Moser, Dr. Burns, is histotripsy something that could be done before or after Hepzato, just like from an interventional radiology standpoint?
Yeah, and I know we've had patients who have had both Hepzato after and prior to this therapy, and so that doesn't limit things. I guess the situation could be, maybe you've had Hepzato, you've had a great response, and maybe there's one lesion that's growing, or something like that, where you have isolated growth in a lesion, and this could be a beneficial procedure to target that, especially since it's not invasive. So I think that this therapy, could exclude you from certain trials, but it shouldn't exclude you from another liver therapy. And again, having prior surgery, Hepzato, Y90, that doesn't exclude you from being able to get histotripsy if that were to be an option for you.
Okay. And then kind of on the flip side, I know we've talked about the RP2 trial, and when there's a trial, you guys correct me if I'm wrong, but if a trial would not necessarily allow for like simultaneous other treatments to happen, right? If you're getting the RP2 injections, you're not going to also be able to go and have histotripsy done on a rogue lesion or Hepzato done on the whole liver or try a different immunotherapy than the nivolumab that's in the trial. So excluding the RP2 trial, can Hepzato and or histotripsy be done alongside, say, Ipi/Nivo or some of the other like tebentafusp, like the ones that are approved that are not in trial?
Then before we go to that question, I just wanted to, sorry, before I forget,
No, you're
mention
good.
on the RP2 trial, there's an amendment that hopefully is going to allow patients that have localized liver therapy. So Hepzato or Y90 that treat the whole liver or immunoembolization, unfortunately, are not going to be allowed on the study. But patients that have had previous localized radiation therapy or histotripsy or let's say cryoablation, they're going to be allowed on the study if they have disease progression.
Yes, and that is definitely coming, but like she said, like it's just not fully amended yet. So just keep an eye on that with your doctors as far as the RP2 study goes. But Dr. Moser, I think you were about to jump into my other question as well. Like, can we do Hepzato and not have to stop, say, Ipi/Nivo or tebentafusp, or like how does that work?
Yeah, so off a trial, we absolutely can do it. There was a small study out of Europe, the Chopin study, which suggested maybe it's more beneficial, but we don't know. They have done a randomized study of Hepzato with combination immune therapy. It was a little bit different. I believe they only got 2 cycles of Hepzato, not the full 6, and then they got up to 4 doses of Ipi/Nivo, 1 dose before, 2 doses in between, 1 dose after. That randomized data, I think, is going to be presented at ESMO next month. And so next month, we'll know if it is better or not. It may be, it may not be. So can we do it? Yes. Should we do it? To be determined.
Okay, I think that's great. Dr. Carvalho, do you have anything else you want to add here?
There's so many more tools that we have kind of at our disposal, which is amazing. Like histo adds to that. And so we just have to figure out how to use everything the right way. Who are the right patients? What's the right sequence?
We really do have to approach this, patient to patient, and everybody gets to kind of have their own nuanced way of doing things. And they're just trying, I mean, doctors are trying their very best to just make sure patients have quality of life and the best outcomes possible. And that's going to look a little different for everybody. We do have one question in here that says, is there anything that would work with a metastatic tumor in the soft tissue of the mediastinum? And I think that would maybe be back to the systemic area, right?
I mean, I would say, the question is when do we do it's kind of like spot treatments? When's the right time to kind of do spot treatments if they're isolated lesions elsewhere? And
Mm.
a lot of times we can do them, whether it's, surgery or radiation or,
Okay.
does it help?
I guess maybe just for those of us in the audience who don't know what the mediastinum is, what is that?
It's the center of the chest.
Okay, the center of the chest.
It's
So
a
just kind of
complicated-
those random isolated occurrences of little lesions that pop up. Just because I know this question could come up for somebody, is histotripsy something that could be used in that regard yet, Dr. Burns?
I would say restricted to the liver at this point. So I would say no. Think about this like this is like a new technology, and we have to figure out how to best apply this to different organ systems. So this could be like kind of early days of developing radiation, and now obviously that's done throughout the body everywhere.
Yeah, for sure. Dr. Moser, Dr. Montessori, thank you so much for your time. Dr. Burns, thanks for jumping in and telling us a little more. If you guys have any other questions, please feel free to send us an email at contact@AcureInsight. And if we can, we'll send those off to the doctors that they are relevant to talk to.